and I'm going to grab my notes for Dr. Huntley. Dr. Huntley is back with us. It's been a few years, right? But I think it's timely. You guys had asked, when I did a survey, you guys had asked about hypoglossal nerve stimulation and the latest developments in that. And there's quite a few developments and some new things coming onto the market. I lost my notes. Anyway, I lost my notes. Anyway, doesn't matter. Dr. Colin Huntley is from Thomas Jefferson University. He is an otolaryngologist. He is well known. Oh, here they are. Dr. Huntley's like, oh my God, this guy. Not the least bit professional. He now remembers why he hasn't been here in 5 years. Dr. Colin Huntley is the Associate Professor of Otolaryngology, Head and Neck Surgery and Sleep Medicine, and the Associate Residency Program Director at Thomas Jefferson University. He is board certified, a board certified and fellowship trained sleep specialist. He's going to bring us up to date on hypoglossal nerve stimulation, what's happening, and I'm excited to hear this because there's a lot going on. Take it away, Dr. Huntley. Yeah, let's say somebody switched it. Just see if the switch is on. Yeah.
Now it's
yeah.
yellow. Now it's green.
There we go.
Goes.
And there's your.
I swear it was green.
Good.
Thank you, everyone, for having me. I'll talk fast so we have time for questions and everyone gets out of here on time and gets to the craps tables. So I'm Colin Huntley. I'm from Thomas Jefferson University, and we're going to talk about hypoglossal nerve stimulation. So these are my disclosures. I have some research support from both NICSOA and Inspire and a consultant for NICSOA. So these are all hypoglossal nerve stimulation companies. This is what we're going to talk about. We should treat sleep apnea, and we'll talk about why. We'll talk about the history of hypoglossal nerve stimulation and then the current state of hypoglossal nerve stimulation. Please interrupt me if there's questions or comments. We can make this a discussion more so than me talking for 45 minutes, but I guess raise your hand or whatever works. All right, this is repetitive. You've talked about it all day, but we'll go through our obligatory slide about what is OSA. So recurrent episodes of nocturnal upper airway collapse. This leads to ventilatory disruption, activation of the sympathetic nervous system, and then subsequently issues with quality of life. So snoring, sleep disruption, morning headaches, daytime sleepiness, et cetera, and also, physiologic consequences. So hypertension, AFib, coronary artery disease, stroke, so on and so forth. The diagnosis was established in 1965 with the advent of the polysomnogram. However, mention of sleep apnea or the sleepy guy or snoring dates back hundreds and thousands of years. These are excerpts from some of Charles Dickens' novels. So this is Joe the Fat Boy. This is one of his characters from, I think it was the 1830s when these were being published. But the excerpts sound like most of the patients that we're seeing in clinic and in the sleep lab on a daily and nightly basis. So, sleep, said the old gentleman. He's always asleep. Goes on errands, fast asleep, and snores as he waits at the table. That sounds like most of the patients that are walking in my office. Joe, said the stout gentleman. When the citadel was taken and the besiegers and besieged sat down to dinner, damn that boy, he's gone to sleep again. This is 1830, so way before the official diagnosis of OSA. And people have posited that this Joe was likely a Pickwickian patient and not necessarily obstructive sleep apnea, but certainly posits or displays some of the symptoms. All right, so what causes obstructive sleep apnea? There's a number of things. Anatomic airway obstruction is a easy thing to conceptualize. So someone with big tonsils, they're clogging the pipe and creating some obstruction. Neuromuscular tone is a common one as well, and we're going to talk a lot about that as we go through hypoglossal nerve stimulation. So this means limited tone or relaxed tone of the tongue, with the tongue falling backward into the airway, decreased activity or decreased tone of the pharyngeal constrictor muscles, leading to some collapsibility of the throat for kind of an imprecise location. And then the neuromuscular tone of the tongue is what's being hijacked with the technologies that are stimulating the hypoglossal nerve to open up the airway. P-crit, loop gain, arousal threshold, these are all contributors to airway collapsibility, the stability of sleep, and the response of the airway to disruptions in sleep, and all are related to and play a role with airway collapsibility and sleep disorder breathing. So why does it matter? Well, sleep apnea is common. This is a systematic review from probably 5 or 8 years ago, but a well-done study with included 25 different papers. When they defined patients as an AHI over 5, so anyone with obstructive sleep apnea, up to 40% of the population had this diagnosis. It was more common in men, more common as patients aged, and more common as patients gained weight and as the BMI went up. When the endpoint was an AHI over 15, so I guess we could say clinically significant obstructive sleep apnea with either moderate or severe disease, up to 20% of the adult population had this diagnosis. And same type of thing, increased in older age groups, increased as the BMI went up. And we know that it leads to poor sleep quality, daytime fatigue, risk of hypertension, risk of cardiac arrhythmia, coronary artery disease, and heart disease, stroke, among many other things. So it's common and it is very impactful for people. Whenever you put a talk together, you inevitably Google. So part of my Google search was, all right, how common is sleep apnea now? And these data points are from the National Council on Aging. And they estimate that there's almost 1 billion people worldwide with obstructive sleep apnea. In the US, there's about 39 million people with obstructive sleep apnea. However, only about 6 million are actually diagnosed with the disease. So there's a lot of patients out there that are affected by this but aren't treated or aren't diagnosed. Further data about why we should care about it. So it's impactful not only from a symptomatic perspective, but it leads to increased cardiovascular risk. This paper looked at the Wisconsin sleep cohort. So this was a large cohort that was followed over decades, thousands of patients followed over decades, with multiple different endpoints that were evaluated. This specific paper was looking at coronary heart disease. So their endpoints were need for a catheterization and stent, heart attack, all-cause cardiac mortality over the course of their study period. And these were patients either without OSA or with OSA. And they were followed for, I think the endpoint was at 24 years after the initiation of the study. And it was 1,100 patients, a little more than 1,100 patients. I just highlighted a couple data points here. So when you would, this is rate per 1,000 person years, but this is the more poignant column, so adjusted for age and sex. If you have severe apneics, the risk of these coronary endpoints over the course of 20 to 25 years is really significant with anyone with either moderate or severe disease. So the risk of these endpoints is significantly elevated if their sleep apnea goes untreated. Same thing with stroke. This paper is almost 20 years old. It had about 1,000 patients in it, and their endpoint was stroke over the course of 3 to 4 years. And look at the risk. They don't mention or they don't describe why they set a cutoff of an AHI over 36, but severe apneists have a significant increase in stroke over that 3 to 4 years if their sleep apnea goes untreated. So it's an independent risk factor for stroke as well as cardiovascular disease. And then what about cost? This study was sponsored by the American Academy of Sleep Medicine in 2015, and these numbers are in billions. So untreated sleep apnea costs society, they estimate $150 billion every year. And you can see this broken down, comorbidities and the cost to healthcare for the cardiac and the cerebrovascular issues. motor vehicle accidents, workplace accidents, and then loss of productivity, it's very costly to society to not diagnose and not treat this disorder. So what are the goals of treatment? Any person that comes in with snoring or prior diagnosis of sleep apnea, we kind of go through each of these bullet points. And in no particular order, you want to make sure that you're improving symptoms. So you want the person to improve, see their snoring improve, their sleep quality improve and consolidate, their morning headaches go away, their daytime sleepiness go away, and then their spouse be less angry at them and invite them back into the bedroom. You also want to mitigate that cardiovascular risk, so decrease the risk of them having a stroke, having a heart attack. And I would argue that if we can get that AHI less than 15, we have sufficiently mitigated that cardiovascular risk. And the last thing we'll say is make an accurate diagnosis. Not everyone just has sleep apnea. There's 81 sleep disorders within the ICSD, and a lot of patients show up with more than just obstructive sleep apnea. There's a lot of insomniacs, there's a lot of patients with restless legs and periodic limb movement disorder. If you just assume they're having poor sleep because of their apnea, you're gonna miss out a lot, and the likelihood of a terrible insomniac tolerating CPAP or an oral appliance or a hypoglossal nerve stimulation device or having successful improvement in their symptoms after any kind of surgery is very low. You gotta evaluate and manage the whole patient. This is our intake form, which unfortunately is not projecting very well, but we have every new patient that walks into the office fill this out. It's basically the first page out of any sleep medicine textbook. And we want to screen them for other sleep disorders and get an assessment of how sleepy they are and use some other validated questionnaires to assess their sleep patterns and their daytime symptoms. And it's not perfect, but it certainly gives us some insight into what else could be going on besides just their snoring and excessive daytime sleepiness. These are a couple papers we wrote in the last few years, but looking at the impact of insomnia. So I'm a sleep surgeon. The majority of the patients that I see that are coming into the office have already been through sleep medicine and tried CPAP and have not done well. And when we assessed what percentage of those patients that are coming in have comorbid insomnia, it's 42%. So almost 50% of the people walking through my door have an abnormal insomnia severity index, have been treated with sedative hypnotic medications in the past, or have been told you have insomnia in the past. What percentage of those patients would do well with CPAP if their insomnia was adequately assessed and managed right from the get-go? That's a positive question, but it's common. And then we looked at the patients undergoing hypoglossal nerve stimulation and said, hey, what is the impact of insomnia on the use of this therapy? And not unsurprising, the adherence and the usage of this device was much lower or significantly lower in patients with comorbid insomnia than it is in patients without an abnormal insomnia severity index or not on these medications. There was more frequent pauses and the total nightly usage was less, which makes sense. So we've got to evaluate and manage the whole patient. All right, so anyone who walks in the office, if they haven't tried CPAP, we always try CPAP. It's a great option. It's very effective. There is very good data showing reduction in the AHI, reduction in the hypoxemic burden, improvement in quality of life metrics of snoring, sleep quality, daytime sleepiness, mood disorders, fatigue, blood pressure. We all believe that it improves the cardiovascular variables as well. I only put these in italics because we don't have prospective studies confirming that. That data does not exist, and that is largely limited to the usage of CPAP even in controlled trials. But single center studies, retrospective studies, observational studies are showing improvement in cardiovascular variables, and we all believe that if you control the apnea with CPAP or through other means, you're going to see improvement in those cardiovascular variables like high blood pressure, cardiac arrhythmia, stroke, so on and so forth. So this is the issue with CPAP. Medicare says that to be compliant, you need to use it 4 hours a night, 5 days a week. The compliance rate is all over the map in the published literature, anywhere from 20 to 80%. So patients that sleep well with it, wake up feeling refreshed, more functional during the day, they keep using it and they do wonderful with it. It's a great option. But there's a lot of patients who just struggle with CPAP, regardless of mask change, pressure adjustment, humidity adjustment, to try and optimize things, and they just can't use it long-term or don't use it long-term. This paper, one of the issues I've found in looking through the literature about CPAP use and CPAP compliance is most of the data points are very short after the initial diagnosis and prescription of CPAP. So they're looking at patients 2 months, 3 months, 6 months after CPAP prescription. There's not large number long-term studies looking at compliance at 3, 5, 10 years. That just doesn't exist. In fact, this paper is the longest follow-up I've been able to find answering this question. So they started with 400 patients. All of them had clinically significant sleep apnea and were prescribed CPAP. At the end of 43 months, which was their endpoint, their compliance rate was 34%. So only a third of patients were still using CPAP 4 hours a night at 43 months after institution of therapy. 60% of their patients were lost to follow-up. That's a huge proportion of that patient population, simply because it is a tough thing to sleep with. So if we take some of these data points and we do a little cocktail napkin math, and we say we got 40 million patients, an estimated 40 million patients with sleep apnea. However, only 6 million are actually diagnosed, and only 34% are adequately treated with CPAP long-term if we extrapolate the data from that last paper. Well, we've got 3.9 million people who have been diagnosed and are inadequately treated, and 34 million who are undiagnosed. And you start to understand why this costs society $150 billion in health issues and lost revenue and lost productivity. So there's lots of alternatives to treat sleep apnea. Weight loss, positional therapy, oral appliance therapy, more traditional pharyngeal or tongue-based surgery, orthognathic surgery for the jaw. Hypoglossal nerve stimulation is simply one in a laundry list of options for a lot of patients that we consider and look at and try and customize for the individual patient. Each one of those options is a lecture in and of itself. But this is what we're going to talk about for the next half hour. Any questions at this point? No one's interrupted me yet. Okay. So this is an alternative option for select patients, and we'll talk about what some predictors are that we've been able to identify for success or who's going to be a good candidate for this. And it's used for obstructive sleep apnea, so it's not used for central disease at all. So we'll talk a little bit about history. We said that sleep apnea was initially diagnosed in 1965 with the advent of the polysomnogram. Initially, a lot of people assumed it was because of obstruction at the level of the larynx or at the level of the vocal cords. This guy Gestalt postulated that obstruction could be because of the tongue moving backward and creating an obstructive location to lead to the issues. Fast forward, and this group does one of the first sleep endoscopies. We'll talk a little bit about that moving forward, but it's essentially looking with a camera and evaluating the airway while someone's sleeping and trying to assess the location of the upper airway collapse and what the pattern of the upper airway collapse. And they had a Pickwickian patient that they described obstruction in the oropharynx causing the sleep disorder breathing in that patient. Then around that same time, neuromuscular research looking at the different airway muscles and what's the function or what's the activity of those muscles during sleep and during these obstructive events. So Guilleminault was at Stanford and showed decreased activity of the pharyngeal dilator muscles during obstruction. So those are the pharyngeal constrictor muscles. It's essentially the muscles that make up the side of the throat. They're on the outside of where the tonsils would be. And they saw decreased EMG activity or decreased tone, I guess is another way to say that, of those muscles. And it's not a difficult logic jump to say if you have decreased tone in those muscles, you're going to see increased collapsibility and obstruction at that level. This group showed also decreased genioglossus activity during these obstructive events. The genioglossus muscle, we'll see in a couple slides, is the main protrusor muscle of the tongue. So it's the muscle that's primarily responsible for causing the tongue to move out of the mouth or move forward. And again, it's not a difficult logic step to say if the muscle that causes the tongue to move forward has decreased activity or has limited tone, it's then going to be collapsing backward and potentially obstructing the airway. So those initial studies then led to animal models. These were done largely with dogs, but what we saw was decrease in upper airway resistance with stimulation of that genioglossus. So if you cause the tongue to stick out, there's a decrease in the resistance through the upper airway. Same thing, decrease in upper airway resistance with stimulation of the geniohyoid. So this is another muscle that helps to protrude the tongue. It's not as strong, or it's not the main protrusor muscle of the tongue as opposed to the genioglossus, but that also has an effect. And then stimulation of that genioglossus helps to limit the airflow restriction and alleviate or overcome those obstructive events. So this is the basic anatomy of the tongue. You have two different groups of muscles that make up the tongue. There's intrinsic tongue muscles. So those are small muscles within the body of the tongue that allows for the fine movements, or that's what allows someone to curl their tongue. And then you have the extrinsic tongue musculature. So this includes the styloglossus, hyoglossus, genioglossus. These are for larger tongue motion. They cause the tongue to stick out, move back, pull from one side to the other. And we'll get to this a little bit more, but then you see the hypoglossal nerve. And this is the nerve responsible for motor function of the tongue. So there's branches that innervate or supply those individual muscles of the tongue, so the styloglossus, hyoglossus, genioglossus, geniohyoid, and then as that nerve travels distally, the intrinsic tongue muscles for kind of fine motor movements of the tongue. So the initial studies looking at just the muscles of the tongue and what impact does that have on airflow and sleep disorder breathing events, and then leads to research looking at stimulation of the hypoglossal nerve itself. So what the initial study showed that if you stimulate the hypoglossal nerve, you see an impact or improvement in airflow during inspiration and critical closing pressure, or P crit. We also see improvement with both distal or proximal stimulation. So what that basically means is, regardless of if you stimulate the tongue out here or stimulate the nerve out here or back here, you see improvement. However, if you stimulate these lateral branches that are going to the muscles that cause the tongue to move backward, you're not going to see the same amount of improvement, which makes sense. If you cause the tongue to stiffen and stick out, the airway opens. If you cause the tongue to pull back, it's going to close. This led to the initial feasibility study with the Inspire device, or the development and the initial feasibility study with the Inspire device. They developed an electrode that had 3 cuffs, or a cuff with 3 electrodes in it that gets wrapped around the nerve. And they saw that you see improved peak airflow by putting that around the hypoglossal nerve and stimulating the nerve, and causing the tongue musculature to contract and the airway to open. No injury from chronic stimulation. And then this led to support for further or future clinical trials. So their first feasibility study included patients with an AHI over 10. The first device had the cuffed electrode that sat on the nerve, the IPG, which is essentially a modified or retrofitted pacemaker, and then a respiratory sensor that was drilled into the sternum. As with any feasibility study or initial trial, there was some technical challenges, but what they saw was improvement in AHI, specifically in patients that had selective manometry findings. So manometry is a pressure catheter that allows you to get a sense of where the collapse might be. So patients who primarily had collapse at their tongue base did better than patients who had collapse elsewhere seen on manometry. And what they found was no long-term consequences to stimulation of the tongue in the initial cohort. And that initial study then prompted development of the second generation device. So this had that similar cuffed electrode that goes on the nerve, the IPG, which is the computer and battery pack, and that's sat in the chest, and then now a third incision for the sensing lead, which is now a pressure sensor, sitting in between the ribs or in the intercostal space, right in between the internal and external intercostal muscles. And their feasibility study with that second generation device was a two-part study. The first part was looking at kind of the 22 patients, I think it was, that they implanted with the device, and the second part trying to evaluate patient characteristics of response. And what they saw was that lower BMI and lower AHI were predictors of response with that device. And then also lack of complete concentric collapse at the palate on their sleep endoscopy. And that's kind of a buzzword that a lot of patients will say simply because it has become an indication for Inspire hypoglossal nerve stimulation as per the FDA guidelines. And we'll talk a little bit about that, but it's, and show you a video, but it's basically a pattern of collapse of the upper airway behind the soft palate that in a very small cohort here was shown to be an independent predictor of lack of response, and then subsequently led to the initial FDA criteria. Uh-oh. Oh, here we go. So the whole purpose with this device, with hypoglossal nerve stimulation, is to cause, like as we said, cause the tongue to contract and move forward, and open up the airway at the level of the tongue base with the hope that we're going to see some coupling to the palate as well. So this is a patient that was implanted with the Inspire device, and you'll see contraction and movement of the tongue, and then I'll repeat that, and then also watch the throat. And you're seeing contraction of the strap muscles, the geniohyoid hyoid, and then the strap muscles, which are the muscles that support the voice box. So the idea being you're stabilizing the voice box as well to limit collapsibility in the hypopharynx or further down past the level of the tongue base. When we look from above as an endoscopic view, so this is a camera placed through the nose, and you're looking down, and this is the voice box here. This part right here is the uvula, so this is the soft palate, and then you can see the tongue further down, and you're seeing contraction of the tongue and movement of the tongue forward to open up the airway. It seems violent. It's not. It's not at least the patient perception of that stimulus is not as aggressive as this seems. Looking at PSG characteristics after patients are implanted and stimulated, you don't even see arousals with this at thresholds that are required for at therapeutic threshold levels of voltage. It doesn't tend to disrupt sleep. It doesn't tend to wake them up at all, so they tolerate this very well. So where are we today? There are currently 3 devices in existence that are at least at the stage of clinical trial or FDA approval. So the Inspire device is the only device that has FDA approval currently. The other 2 companies are Nyxoah and LivaNova, and we'll talk about these as well. These are undergoing clinical trial right now, and with the ultimate goal of FDA approval. But they're still considered quote unquote experimental and not approved by our FDA. There's a number of additional startup companies that are exploring the space as well and developing technology, but those are at various stages of development, none of which are past feasibility study and clinical trial. So this is the same picture we saw earlier. The hypoglossal nerve, whoops. So the hypoglossal nerve is a purely motor cranial nerve. So it comes out of the brainstem. It travels inferiorly or down in the neck. It traverses the carotid artery, and it runs deep to the submandibular gland, so the salivary gland that's right here. And that submandibular gland, I keep pushing the wrong button. That submandibular gland sits right here. So this is all just deep to that gland. This is a purely motor nerve, as I said, meaning it is only responsible for movement of the tongue. There's no sensory effect to this nerve. It has a fairly reproducible and predictable branching pattern. So proximal or early on in the nerve, you're seeing branches that are traveling to the hypoglossal and styloglossus. We'll talk about this nerve here. So this is C1, and it's part of something called the ansa cervicalis. That'll become important on the very last slide. But that nerve innervates or supplies motor function to the strap muscles, so the muscles that support the voice box, the thyroid or Adam's apple cartilage in the hyoid bone. And then as we travel distal on the nerve, we see branches to the genioglossus and then the intrinsic tongue musculature. The whole idea behind hypoglossal nerve stimulation with at least the companies and the devices that we're going to talk about is to selectively stimulate the muscles that are going to cause the tongue to move forward and to stiffen, simply to open up the airway behind the tongue and stiffen the tongue to just decrease the overall size, or flatten the tongue and decrease the overall size of the tongue and create more room for airflow. So we'll start with the Inspire device, simply because this is the only FDA-approved device. It's been FDA-approved since 2014. In its current configuration, there's a cuffed electrode that sits on the nerve, and it's sitting distal on that nerve to only stimulate the intrinsic tongue muscles and the genioglossus muscle. There's an IPG that sits on top of the pec muscle, so underneath the subcutaneous tissue in the chest, and then a respiratory sensor that's sitting in between the ribs, so in between the internal and external intercostal muscle, in between the ribs. We put it in through 2 incisions. So the incision up underneath the jaw or at the level of the gland, the recommended incision is 5 centimeters. You don't need 5 centimeters. You need about an inch and a half incision to be able to adequately access that nerve and safely place this. And then this incision is about 2 to 2.5 inches, and that's just simply to accommodate the size of the generator, the computer and battery pack device. I have a typo here. The BMI limit is not 100. So these are the current FDA indications. They've changed recently, but this is currently what the FDA says Inspire is indicated for. So AHI from 15 to 100, less than or equal to 25% of those events being central in nature, a BMI less than 40, so not 100, but 40. They've been either intolerant to or failed CPAP, meaning they have persistent apnea despite use of CPAP, and then lack of complete concentric collapse on sleep endoscopy. We all work in American healthcare, and I think we all understand that what the FDA says and what insurance companies recognize are different. So these are not what are recognized by most insurers currently. Most insurance companies recognize AHI from 15 to 65, BMI less than 35 with these same other data points. But recently, the FDA has expanded their indications. So this is a sleep endoscopy video. Drug-induced sleep endoscopy is a sedated exam of the upper airway. Traditionally, we use propofol for sedation, but there's, at least in this country, other countries use other sedative hypnotic agents. In peds, there's other medications that are done, but in adults, it's almost exclusively done with propofol in our country. We take a fiber optic scope and place it through the nose, and we're evaluating the soft palate, the sides of the throat, the tongue, and the voice box. There's a number of maneuvers that you do during this exam. So the patient is positioned in various ways, meaning supine and non-supine. We manipulate the jaw, so we'll close the mouth or gently protrude the lower jaw. And that's trying to get a sense of what happens to the airway with some of that manipulation, and is an oral appliance likely to be successful in someone by simple, gentle manipulation of their jaw. We'll also put CPAP on. That's not standard of care, but it's being done at select places, and I think your next talk is about CPAP during sleep endoscopy. But that gives us some data points about airway collapsibility and then subsequently success with various interventions. We'll talk a little bit about that moving forward. So I'll play this video. We start in the nose. So the palate is on the bottom. This is the back wall of the nasopharynx, so the very back of the nose. And this is AP collapse. So this is what you traditionally want to see for hypoglossal nerve stimulation. And you get a sense that that soft palate is closing in a front to back fashion. And as we descend, you'll see the tongue come into view. You see the sides of the throat. This is the voice box further down. And you're seeing that tongue as a common source or a large source of obstruction. Then as we apply CPAP, you see the airway pop open. So that was just a small amount of CPAP pressure. I think that was 6 or 7 centimeters of water. But you can see that splint effect of CPAP. So how about outcomes with hypoglossal nerve stimulation? So this is the initial outcome study for the Inspire device. This is from 2014. And they had 126 patients. Their median preoperative AHI is 30 to 31 in their different study groups. Their postoperative AHI in a full night efficacy study was 7. I specifically say full night efficacy study because you can either do a full night efficacy study or a titration study. Titration, very similar to a CPAP titration, where patient is placed in the sleep lab and different voltages are explored throughout the course of the night. You cannot assess post-operative outcomes with a titration study. The vast majority of people in my shoes doing academic sleep surgery do not feel a titration study is adequate to assess post-operative outcomes. You need a full night efficacy study of some shape or form, whether that's a home test or an in-lab study at one single voltage. But a titration study is just not good enough. 30 minutes in N1 sleep on their side, sure, everyone looks great regardless of what their stimulation level is. Just like 30 minutes of N1 sleep at 5 centimeters of water in the non-supine position is probably going to be effective for most patients on CPAP. So I bring that up because this was full night efficacy study. And then those patients were followed out for 5 years with sleep studies at various time points and data points to assess Epworth score, so excessive daytime sleepiness, FOS score, so to assess fatigue, and then this is just response rate. And what you see is persistent maintained reduction in the AHI, persistent maintained reduction in the Epworth score, FOS, and response rate over the course of 60 months or 5 years. This paper is from the ADHERE registry. So ADHERE was a multi-center, multinational registry study where patients implanted with the Inspire device were followed for that first 12 months, and a number of endpoints were assessed. So AHI from baseline to that post-treatment, and this says post-titration. This was a mixture of both titration and full night efficacy AHI at that 12-month mark. And then I just put the Epworth numbers here because you see normalization of the Epworth score, but there was a number of other variables that were assessed among this registry, quality of life-wise, also data from their sleep studies such as hypoxic burden. But these are just two endpoints from this trial. This initial study, which had just about 300 patients in, I believe, also looked at complication rate. So hypoglossal nerve stimulation is surgery. It requires surgery to implant it. Anytime we operate on someone, we worry about complications. With any medical device, you worry about both medical and device-related complications. So medical complications or surgical complications are things like weakness of the nerve, infection, bleeding. Those are all extremely low with this. And then there's device-related complications, which are related to stimulation itself. So this is a very well-tolerated therapy. It does not tend to wake people up. They don't have this arthria or trouble speaking once the device is turned off. They don't have long-term issues with swallowing, simply because the tongue has been contracting all night. This is another paper from the ADHERE registry, again, showing efficacy. So this is about 500 patients, I believe. But again, significant improvement in that AHI, and this is a mixture of titration and full night efficacy study, and improvement in maintenance in the Epworth scores to a normal value. This study, there were also regression analyses done to try and assess predictors of success with this device. So what are some individual patient variables that were predictive of response to Inspire hypoglossal nerve stimulation? So women did better than men. So as most things, women did better than men in this study, but female gender was an independent predictor of success with this. BMI is meaningful. So lower BMI meant higher likelihood of success. For every 1 point the BMI decreased, the success rate went up by 8%. So BMI is a meaningful variable. This is another study done by Dr. Hewitt, he was a fellow when he did this. I'm pretty sure he was told he was doing this study. But he compiled sleep endoscopy videos of, I think it was 400 patients who had undergone hypoglossal nerve stimulator implantation from multiple centers across the country. And a number of the authors blindly reviewed those videos and scored them with the effort to try and predict specific variables that were, or identify specific variables that were predictive of response or predictive of lack of response with this type of therapy. And what they found was obstruction at the sides of the throat, so the lateral walls of the oropharynx, were an independent predictor of lack of response to this type of therapy. And that was seen anecdotally. We had talked about that anecdotally before this study came out, and it just kind of confirmed that theory and that hypothesis. We also saw that primary tongue-based obstruction was a statistically significant predictor of response, but the clinical impact, I guess we could debate. CPAP pressure. So you're going to talk about this in the next talk as well, but CPAP pressure required to treat the sleep apnea and CPAP pressure that we see opening the airway during sleep endoscopy is predictive of success or response with this form of therapy. There's older data looking at oral appliance therapy and lower CPAP pressures predicting response with oral appliances. There's some data among, excuse me, within the literature of more traditional surgery that shows a relationship as well. The corollary is lower CPAP pressure likely means more responsive airway or less collapsible airway, and those patients tend to do better with hypoglossal nerve stimulation. So both of these papers were written at the University of Pennsylvania, or from authors at the University of Pennsylvania. This first one was either 95th percentile pressure from a CPAP download or a CPAP titration study. And what they showed was that patients with CPAP pressure less than 8 centimeters of water tended to do better. This follow-up study was CPAP pressure required to open up the airway during sleep endoscopy. And again, 8 was another common cutoff where less than 8, the positive predictive value of that had a high positive predictive value of someone responding to hypoglossal nerve stimulation. So that's a summary of data regarding Inspire. There's a lot of Inspire papers out there simply because it's been around for 10 years. We'll talk about some of the other kids on the block. So LivaNova is another company. They have this Aurora 6000 device. There are a few papers that have evaluated the outcomes of this, and it's currently undergoing additional clinical trial. It consists of an electrode that sits on the hypoglossal nerve, and then the implantable pulse generator down in the chest. This technology is a little bit different. So Inspire has 3 cuffs that sit around the nerve, whereas this has 6 electrodes that are circumferential around the nerve or trying to stimulate different areas around the circumference of the nerve. And the whole idea here is after the patient is implanted and heals up, you're trying to find a combination of those electrodes that's going to stimulate the tongue to stiffen and flatten. So you're trying to decrease the size of the tongue, stiffen the tongue, and limit the collapsibility or limit the tongue falling backward, as opposed to the other technologies that are actively moving it forward. So their initial outcome studies, this first study, they enrolled 93 patients, 46 were implanted, 43 followed up at 6 months. And what they saw was an AHI reduction in this initial study from 35 to 25 at 6 months. So that was statistically significant. Clinically, we can debate. Of their responders, you saw a reduction in AHI from 35 to 8.5. So the question is, what predicts a responder? And that's some of the data that's being evaluated through future clinical trials, but this is just their initial study. Fast forward, and the same device, they published their targeted hypoglossal nerve stimulation trial. So this is the second series of studies for this device. So they had 138 patients initially. They implanted 138 patients. That was then separated into two groups. So 92 patients in a treatment group, 46 in a control group. The treatment group was turned on and activated at 1 month and then followed for the following year. The control group, they left therapy off until 4 months. There was a sleep study done of both groups at 4 months, and then a final sleep study at the 1 year mark. And what we see is that 4-month sleep study, the success rate in the treatment group was 52%. Success was defined as a 50% reduction in AHI to a level less than 20. Interestingly, 20% of the control group also saw success, so that just talks about the night-to-night variability you see with sleep testing. At the 12 to 15-month endpoint, where the whole cohort of 138 patients had their post-op sleep study, 42.5% met their study endpoint, which was that 50% reduction to an AHI less than 20. Just similar data in graphical form. You see the whole cohort starting off at an AHI of around 35, with then a reduction to the high teens with therapy in place, or with this therapy in place. So the current status of the LivaNova device is that still undergoing clinical trial. The current trial is called the Osprey trial. It's recruiting now at a number of institutions around the country. So last but not least is Nyxoah. So this device has a similar, incorporates a similar concept. You're stimulating the nerve, the hypoglossal nerve, to cause the tongue to contract, move forward, get the tongue base out of the way, and open the airway. The difference here is it's bilateral. So you've got this butterfly-shaped implantable device that has a wing that straddles or stimulates both sides of the nerve, or both nerves, and then the electronics sitting right in between. This is implanted through a 2 to 3 centimeter or 2 to 3 inch incision that's just under the chin. At night, after the patient heals up, they're wearing an adhesive patch that sits just on the skin overlying that. And the brains of the device is the computer and the battery that connects to that patch. So a number of variables or a number of functions that are customizable with this, and it has a rechargeable battery. The other interesting thing or different aspect of this device is it works on a duty cycle. So there's no respiratory sensor here. Duty cycle simply means it's on for a set period of time and off for a set period of time. And as the patient is being titrated and evaluated and optimized post-op, you're trying to find the, is my timer going off? You're trying to find a duty cycle or a configuration of on and off that's going to capture the vast majority of the respiratory cycle so that the airway is open during the majority of the respiratory cycle and not obstructing. So initial outcome study with the Nyxoah device, this is the BLAST trial. This was done in Australia, the UK, and France. So they initially consented or enrolled 93 patients, 27 ended up being implanted, 22 followed up at 6 months, and this table is our outcome data. So you saw an AHI reduction in this cohort from 24 down to 13, ODI reduction here. The hypoxemic burden dropped significantly, and then the Epworth score normalized in this cohort as well. So fast forward a couple years to the US trial. So this recently closed, but this was the Nyxoah trial in the United States. Their inclusion criteria were 22 to 75-year-old patients with an AHI from 15 to 65, and these were patients with obstructive apnea, BMI less than 32, and then that lack of CCC or complete concentric collapse on sleep endoscopy. This trial is recently closed. On, I think it was Tuesday, they came out, this past Tuesday, came out with their press release about the preliminary outcomes of this study. So the paper has not been published, but these are just preliminary outcomes of the data set. So they had 115 patients. Pre-op AHI and ODI were 28 and 27. Their shear criteria responder rate. So that's shear criteria is that same 50% reduction and AHI less than 20. That's just a common outcome variable that's used in sleep surgery literature. So their responder rate was 63.5%. The reduction in AHI was 71%. And then the ODI responder rate, 71% as well. What was interesting about this study and evaluated here that's not been really looked at much elsewhere was that position didn't seem to be that much of a factor. Or I guess another way of saying that was the AHI response rate in the supine position was not dissimilar to the AHI response rate in the non-supine position, which begs the question, does this work for supine apnea? Or I guess it begs the question, does hypoglossal nerve stimulation work for positional apnea as well? But I guess further study to be done there. So the current status of the Nyxoah Genio device is DREAM trial's closed, the 12-month follow-up is complete, and they are submitting for FDA approval. Currently, they are running this access trial. So this is not a typo. So CCC means complete concentric collapse. So they're evaluating, or we're evaluating patients with complete concentric palate collapse for this technology as well. All right, last slide. So the future. So briefly mention the ansa cervicalis. So this is a nerve in the neck. It's made up from the first 3 cervical nerves. So the first 3 nerves coming out of the spinal cord. And it innervates the strap muscles. So the muscles that support the voice box. And it causes the voice box to elevate, depress, move forward during swallowing and during speech. The reason we care about this, or we think about this, is because of a concept called tracheal tug. If you pull down on the voice box, you pull down on the muscles that make up the pharynx. If you pull down on the muscles that make up the pharynx, you stiffen those muscles. They're on tension and they're not as collapsible. So if you induce tracheal tug, you limit collapsibility of the airway. There's a lot of old respiratory physiology literature that looks at the impact of end expiratory lung volumes on airway collapsibility, tracheal tug, airway collapsibility, and sleep apnea. Apnics tend to have lower end expiratory lung volumes compared to non-apnics. And there's a number of reasons to talk about this, with abdominal obesity being the most commonly stated reason. But if there's a higher end expiratory lung volume, the lungs are going to pull down on the trachea, which is going to pull down on the pharynx more and stiffen the walls of the pharynx, making it less collapsible. If you have less volume, there's less tracheal tongue and more collapsibility of the pharynx. So if we stimulate that nerve and stimulate those strap muscles to tug down on the voice box and subsequently tug down on the pharynx, you potentially stiffen the pharynx and limit the collapsibility. So this is some very early research looking at this. And you get a sense of size of airway opening. So this is the pharynx here and here. And at baseline compared to just isolated stimulation of the ansa cervicalis. This is a different patient, but you see baseline size of the airway with just hypoglossal nerve stimulation, so just getting the tongue out of the way opens things up, and then size of the airway with hypoglossal nerve stimulation and ansa cervicalis stimulation. That's great. Pictures are pretty, but what does it mean from a physiologic perspective? So this is airflow. So this is no stimulation down here in terms of volume of airflow. If we stimulate the hypoglossal nerve and get the tongue out of the way, you see improved airflow. If you combine stimulation, so you stimulate both the hypoglossal nerve and the ansa cervicalis, you see even more airflow, as opposed to just hypoglossal nerve stimulation as well. So is the future stimulus of both the hypoglossal nerve and the ansa cervicalis? Maybe. That's being actively investigated currently. And what does this do for patients who already meet indications? Does your success rate improve? What does it do for patients that don't meet indications? Does this enroll another subset of patients that could potentially benefit from this? So here's my conclusion. OSA is common and we should treat it. There's multiple options. CPAP's wonderful. It's very effective. However, we need alternatives for those patients that have a hard time tolerating it. Hypoglossal nerve stimulation is one of those options. There's currently one FDA-approved device that works well for appropriately and well-selected patients. And from the data we have now, it seems that BMI, critical closing pressure of the airway collapse pattern, age, and gender are all variables that are predictive of success or affect success of this device or of this technology. That's all I got. Happy to take any questions.
Any quick questions for Dr. Huntley? Oh, you got one, Ed? Didn't know if you were stretching or you're like the guy at the auction that was stretching and just bought the $1 million item.
When you're on CPAP, you get older, you get heavier, usually you go up on the pressure.
Mm-hmm.
What happens with Inspire if you get older and heavier? Can you increase the stimulation?
You certainly can. I think the follow-up question is, what does that do to the outcome? So, and that data we don't necessarily have. So it's been out for, the Inspire device has been out for 10 years. So we've got outcome data from that initial cohort and single center studies. We've got predictive variables, but that's a great question, is what happens over time. Now, age is a predictor for improved success. Maybe the airway's a little less collapsible. Weight is a predictor of decreased success. So you certainly can increase the voltage and the amount of stimulation, but how much is that actually going to move the needle or move the number and control symptoms? Anecdotally, I'll tell you, if people are like, yeah, I have a couple glasses of wine and I snore with my device in, but I don't snore normally, I tell them bump it up 1 or 2 points when you have a couple glasses of wine before bed, and it tends to improve things.
We got 2 quick ones here on Zoom. You mentioned several times a full night efficacy study. With regards to a home study, what was/is your criteria for a full night?
Good question. So lining up, so we're able to assess usage from the download of the device. So pulling up the data from the sleep study in line with usage. I want to know how many times they paused the device, how long was it on, and line that up with what really the hypnogram looks like on their home study. I mean, ideally, it's like any home study. You want as much as you can, but at least 4 hours. It's nice to see a combination of supine and non-supine sleep. And I always tell people to do it for at least 2 nights. I'd rather see multiple nights of home sleep testing to try and capture as much data as possible.
Good. Since we're bumping up against time, if you could stay there, I want you to pick the Apple Watch winner for us. Give Dr. Huntley a round of applause.
Thank you for having me.
Now he's like, oh my God, this guy's a baseball cap on now. How unprofessional is this guy? All right, Apple Watch giveaway. Once I find the numbers, let's give you all, mix that up a bit.
Pick one?
Yeah, pick one. Is there a name on there?
Dilpreet Singh?
Dilpreet Singh. Dilpreet Singh is a Zoom attendee.
Throw it back in?
Yeah, no, it's good. Put it right there. Yeah. Thanks, Dr. Huntley.